From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Today, we'll focus on a major shift in the treatment of myasthenia gravis, as a wave of new therapies is changing how we treat this disease. Who should be considered for these new drugs? And what else is in the pipeline? Our guest today is Dr. Gil Wolfe, neuromuscular neurologist at the University of Buffalo, State University of New York, Jacobs School of Medicine and Biomedical Sciences. Dr. Wolfe was interviewed by Dr. Ioannis Karakis, adjunct professor of neurology at Emory University School of Medicine. Here's Ioannis.
Thank you for joining us, Gil.
Thanks so much for having me. We're going to be talking about new and emerging therapies in myasthenia gravis, and it's a very fun topic to talk about, especially since 2017.
Indeed. So to get us started, the treatment landscape for myasthenia gravis has changed dramatically in the past decade. Can you please walk us through the most significant advances?
No, absolutely. And so, as you mentioned, since 2017, we've had a series of approvals for therapies in myasthenia gravis. And I just want to point out, these are the first immune-mediated therapies for the treatment of the disease. We had no approvals in the United States prior to 2017. Eculizumab was our first targeted therapy approved in 2017. It is a C5 cleavage inhibitor. And what it does is it prevents C5 from breaking down to C5a and C5b. And if you recall, from medical school, C5b is kind of the first template molecule that allows us to make the membrane attack complex. So what's that relevance in myasthenia gravis? We know that acetylcholine receptor antibody positive myasthenia gravis patients, some of them at least, a good proportion of them, have membrane attack complex mediated injury to the postsynaptic membrane. It basically chews up the muscle membrane. So if you can block that membrane attack complex formation, you can engender repair more quickly, perhaps, of the postsynaptic membrane and improve neuromuscular transmission. Since eculizumab was approved, we have two more molecules that have been approved. Ravulizumab, which is basically eculizumab modified by 4 amino acids, so it has a longer half-life. You don't have to infuse it as frequently. Zilucoplan is not a immunoglobulin. It's a smaller molecule that also prevents C5 breakdown to C5a and C5b. How about the FcRn antagonists? How do they work? The FcRn receptor antagonists prevent the recycling, the salvage mechanism, basically, of IgG, all forms of IgG, maybe IgG4 a little bit less than IgG1 through IgG3, but quickly and dramatically, it reduces IgG levels, both good IgG and disease-causing IgG. It's kind of sort of like a pharmacologic approach to plasmic stage, although plasmic stage removes more than just IgG. But anyway, since all of the autoantibodies we know of in myasthenia gravis so far are IgG, that may change down the road, but right now, as far as we know, they're all IgD, at least the ones that seem to cause neuromuscular transmission failure. So it would make sense if you reduce IgG, including those autoantibodies, you would improve the disease state. That's how the other drugs that have been approved work, and that includes efgartigimod, rozanolixizumab, and most recently, nipocalimab, which was just approved 2 months ago. So those are the 6 agents. If you include the subcutaneous form of efgartigimod, we have 7 different molecules now that have been approved in myasthenia gravis since 2017. And again, realize before 2017, we did not have a single immunotherapy approved for myasthenia gravis in the United States. And now we have all of these agents.
It sounds like complement inhibitors and FcRn blockers have been game changers for some patients. What do we know about who benefits most from these therapies, and when should we reach for them?
So as far as these new therapies, they really do seem to work across the MG spectrum with a few limitations. So the first thing I'll mention is we do not have an approval for seronegative or ocular MG, okay? But we do have 2 of the molecules that are approved both in receptor antibody positive and MuSK antibody positive myasthenia gravis. As far as their reach, I'll use that term reach, like which other subpopulations are they effective in? It really works across the board, whether you're a man, whether you're a woman, whether you're young, whether you're old. whether you've had a thymectomy or not. These agents do seem to work across the board. Now, realize the C5 cleavage inhibitors are only going to be labeled and are only labeled for acetylcholine receptor antibody positive disease, because that's the form of the disease where we really have evidence that complement is important, that the membrane attack complex really is playing a role in the damage to the postsynaptic membrane. But beyond that, they really have worked across the board. And the other point I want to make, they really have worked across the different domains of the disease. What do I mean by that? They help from the standpoint of bulbar dysfunction, from limb dysfunction, from truncal dysfunction, and so forth. Now, there may be, and there's some studies, there's like a recent study, for instance, from China, that patients with predominantly ocular disease didn't respond quite as well, say, to an FcRn antagonist. And perhaps patients who've had prior thymectomy did a little bit better as well in an Italian study. So you do see some of these types of small differences, but in general, they have worked across the board.
I see. The treatment of myasthenia has historically relied on agents providing relatively broad immunosuppression to reduce antibody-mediated destruction in the neuromuscular junction. With more targeted therapies available, like the ones that you described, what is the current role of these older broad immunosuppressants?
Yes, conventional therapy is not dead for myasthenia gravis. And it is my strong belief that conventional agents can handle most myasthenia gravis patients, including generalized disease. Realize all these recent approvals are for generalized myasthenia gravis, but conventional therapy can adequately control the majority of patients. But where are these new agents important? When you need a quick response, when you have refractory disease, when patients are basically steroid wrecks. These agents have been shown, at least in open label extension studies, to really spare steroids as well. So these agents are important, but again, I want it to be clear that these targeted agents, which are very expensive, are not needed in the majority of patients. The majority of patients still can be handled with conventional therapy, which includes pharmacotherapies and also, at least in the receptor antibody positive population, thymectomy.
Yet myasthenia isn't one disease. As you alluded to, it has multiple subtypes with various antibody targets, and some patients do not have detectable antibodies in their serum. In that sense, are we entering a new era of precision medicine in myasthenia that targets treatment to these subtypes?
I think we are, and I think we've actually entered an early era of that very scenario that you're describing. So, for instance, we have a couple of the FcRn antagonist agents that are approved both in receptor antibody positive disease and MuSK antibody positive myasthenia gravis. The latest approval actually is also labeled for late adolescents and teenage patients beyond age 12. I think we are going to have an evolution of biomarkers that can help us predict where patients are most likely to respond, whether it's older agents, conventional therapies that we've mentioned, such as even corticosteroids, to the non-steroid immunosuppressants, to the targeted therapies. Which targeted therapy is the best pick for that particular patient? I think we will get there. Take a little while, but I think we'll get there.
That's really encouraging. However, as it currently stands, many trials exclude patients with seronegative myasthenia or LRPR4 antibodies or special populations like pregnant women. What is your current approach to treating these patients?
Well, at least in a refractory adolescent or a teenage patient, you really could consider one of the targeted therapies. In fact, the one that was most recently approved, nipocalimab, because it has that label. Pregnancy, as far as agents crossing the placenta, one of the FcRn antagonists has been found to really not cross the placenta at all, as far as we know. So it could potentially be safe, but we need more data on that. But it would be great to have a greater number of agents available for pregnant women. What do I use when women are pregnant at this point? You can use corticosteroids, you can use IVIG, until later stages when, labor is going to ensue. You can use acetylcholinesterase inhibitors. You can use plasma exchange, but we need other options. Elderly patients, I'm really not all that restricted in elderly patients, except for the fact that corticosteroids become more and more problematic because of the hyperglycemia, because of the potential for fractures, including compression fractures in the spine, the hip, and so forth. Non-steroid immunosuppressants I've been able to use pretty safely in the elderly population. Seronegatives. All right, yes, seronegatives can be difficult not only to identify clearly in some cases, but to manage. And unfortunately, our trials really haven't focused. There have been some seronegatives in some of the trials, some of the FcRn antagonists, but we don't have a label there. And hopefully we'll see a development of new therapies specifically approved for the seronegative population. LRP4, there's been more and more talk about how great LRP4 is as far as a marker for myasthenia gravis. It is nowhere near specific for myasthenia gravis. You see all kinds of other disease states with those antibodies. It's an extraordinarily rare, in isolation, an extraordinarily rare form of myasthenia gravis when you see that antibody in isolation. I don't think it's a huge challenge, the LRP4 patients. They tend to have milder generalized disease. It tends to respond to conventional therapy anyway. And again, I think a lot of the patients with LRP4 antibodies actually don't have myasthenia gravis. So I'll leave it at that.
Thank you. That's truly useful. The truth of the matter is that no matter what we prescribe, ultimately a substantial proportion of patients with myasthenia will end up presenting with a crisis. Is there a potential role, in your opinion, for using these new agents down the road beyond their currently approved indications, including a myasthenic crisis?
Absolutely. And there's growing data, and there's already quite a bit. Now, look, it's retrospective case series type data of impending or manifest crisis, both with the C5 cleavage inhibitors and with the FcRn antagonists. It's growing. Every month, you're having more papers where these agents have been used successfully. During my sabbatical, I was actually involved with a prospective study using one of the FcRn antagonists in myasthenic crisis. And I could tell you the data looks good. These patients turn around. One advantage that I mentioned earlier is these agents work quickly. You can see responses within a few days to a week or two. That's what we need, obviously, in crisis to turn patients around. That's why we use plasma exchange and IVIG, because they work quickly. But yes, we are going to see these targeted agents used more and more in crisis. In fact, I can refer you to a paper, I think it was just published last year, from China by Ma et al. They compared in a retrospective manner, it was a fairly small study, I think it was 19 patients, IVIG to efgartigimod, and actually at a week after treatment, the patients who had received the FcRn antagonist were actually in better shape as far as MG-ADL reductions, and that response persisted up to 4 weeks. And so you're going to see more and more of this data, but yes, there is a role for targeted therapy in that acute clinical scenario of generalized myasthenia gravis.
Thank you. That was a really comprehensive overview of directed pharmacological therapies such as complement inhibitors and FcRn receptor blockers. Can we end by covering any emerging treatments for myasthenia gravis that you think are especially promising?
As far as emerging newer mechanisms of action that may have a promising role in treating myasthenia gravis, there are several that I can mention, and I'm not even going to mention all of them. In the New England Journal of Medicine just a few weeks ago, and I was involved with an editorial about this paper, the MINT trial, which was a trial of inebilizumab, which is an anti-CD19 agent, did show a positive impact in myasthenia gravis. And yeah, it was kind of redemption because we struggled with it earlier trials in myasthenia gravis, but it kind of makes sense that B-cell depletion should work, especially if you knock out the B-cell lineage that creates those autoantibodies, which an anti-CD19 agent should do quite well. We've known for quite some time, even though we don't have a randomized controlled prospective trial, that anti-CD20 agents work very nicely in MuSK-MG, perhaps because the IgG4 antibodies, it's the plasmablasts, at least the earlier plasmablasts, that churn out those autoantibodies. And so we've used rituximab quite successfully in MuSK. But here we have an abelizumab anti-CD19 agent that, like other B-cell depleting agents, offers a relatively simple schedule. You don't have to give these agents every month or every 2 weeks or every 6 weeks or every 8 weeks. These might be infusions that are just needed every 6 to 12 months. They work fairly quickly, maybe not as quickly as the targeted therapies that are already approved, but that is a promising approach. What else? How about the CAR T therapies using T cell mechanisms to act against B cell maturation antigen, BCMA, or say CD20 or CD19, or even a specific antibody in MG? We're already seeing preliminary data that suggests in relatively difficult patients that these therapies have promise in myasthenia gravis. How about oral therapies? Because pretty much everything I've mentioned before has required a needle. Obviously, I think most patients and most providers would prefer oral agents. We have things moving in that direction too. There's complement inhibitors that can be delivered orally, Bruton T kinase inhibitors also. And there's other potential oral approaches. So it's very exciting, not just for myasthenia gravis. And one point I want to make about that very last statement is look at the neonatal Fc receptor antagonist. Yes, myasthenia gravis was the cardinal disease where we saw the initial approvals, but now we have an approval, say in CIDP, and realize the companies are looking at that approach in many IgG-mediated diseases, some 30 different types of both neurologic and non-neurologic diseases. So it's a very exciting time in myasthenia gravis. And then that excitement extends beyond the myasthenia gravis disease state itself.
Great. It sounds like the directed pharmacological therapies that you went over with us offer the advantages of rapid clinical improvement and favorable adverse event profile, but there are many more management strategies that we should stay tuned for down the road.
Yes. And always remember that pretty much with any of these immunotherapies, and that includes the C5 cleavage inhibitors and the FcRn receptor antagonists, there's always a risk of infection, and you got to remember to vaccinate. It's required for Neisseria meningitidis before you use a C5 cleavage inhibitor, and that likely will be in place for any complement inhibition. That is a must. And there is a requirement for prophylactic antibiotics as well, based on the latest language from the ACIP.
Wonderful. We really appreciate your time and expertise, and we're looking forward to the new developments in this field.
Ioannis, it was a pleasure talking to you, and I hope this is helpful for the ANA membership and beyond.
That was Dr. Gil Wolfe of the University of Buffalo State University of New York, Jacobs School of Medicine and Biomedical Sciences, interviewed by Dr. Ioannis Karakis of Emory University School of Medicine. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Ioannis Karakis and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.